Hey everybody, it's Eric with Motion Guidance again. Thanks for joining me today on this Zoomcast. And today we have a really great participant. It's Dr. Jonathan Chung. He is a chiropractor out of Florida, and we have met personally several times over the years. And he is a wonderful follow on social media. We'll get to all that sort of thing. Really big into clinical neuroscience, and he's been using motion guidance products for several years. And so, Dr. Chung, welcome to the Zoomcast today.
How's it going, Eric? Thanks for having me.
Of course, really glad you got time to make it on. I know for a lot of our guests, the last 6 months have been, much more ramped up into what they're able to do because, clinical practice is getting back on its feet and things are turning a proverbial corner, it seems like. So really glad you made some time for us today.
For sure. I mean, I'll be honest, right now we are busier than we were pre-COVID and pre-pandemic. So, we had gone up a little bit, and right when we were kind of hitting our peak and hitting our stride, and obviously COVID kind of, tanked everything. We had to do some telemedicine, telehealth type stuff. But truthfully, a lot of what people have been going through since COVID hit, people are so sick with other issues and they've let other problems kind of fester for a little while. And now we are, kind of as busy as we've ever been, seeing people across a wide variety of neurological issues. So, we've been fortunate enough to be able to see, a lot of these people. And, obviously it's not great that, people are sick, but fortunately, there's a lot of answers for a lot of the things that we're working with, at least here.
Well, that's interesting. If you don't mind, maybe you can give us some examples of maybe some trends that you're seeing around your clinical practice. So I think you're hitting on something big there, and we have research in other areas of medicine to back this up, where people stopped getting care, not out of their own choice, oftentimes, for some serious conditions. I know we've seen that with the different forms of cancer. I was just going through last night, people that famous names that had passed on in 2021. And I think out of a list of 30 people, that the top 30 of whatever they created, this particular journalist, there were 7 people who died of colon cancer last year, which is a very screenable thing. We know when we should start, getting those things. And I just had to wonder if people were, over the past 2 years, they didn't get the care that they needed and the screening tools that they needed or the care that they needed. And of course, that's an extreme example, but go ahead and tell us what you're seeing in your area.
I'm seeing a lot of dysautonomia. So we're seeing a lot of people after COVID, they've been hit with POTS or some milder form of dysautonomia. So we're seeing a lot of orthostatic issues that have come up recently. We're seeing a lot of issues related to stress and anxiety. So a lot of these functional neurological disorders are popping up. So we'll see people with functional movement disorders, some functional pain disorders, and functional dizziness like PPPD and MDDS. So we've seen more of that than I've seen in most of my previous years of practice, because those were kind of rare things for the most part. But I've seen, a dozen or so of those cases in the past year for sure. So those are the big things that I've been seeing quite a bit of, where previous years, when people were out and about, they were driving more, we saw a lot of concussions from car accidents and sporting activities and stuff like that, where now we're seeing autonomic disorders and post-infectious type stuff. That seems to be, and it's the issues related to anxiety for sure.
Fascinating. And super enormous need for obviously the types of care that you provide. Can you, for people who might be listening to this now or in the future, give a clinical example of what you mean by a functional pain syndrome?
So when people have pain, and people usually associate pain strictly with some type of physical or biomechanical type of an issue, right? Mm-hmm. But there's a lot of people that will develop pain issues in the absence of any physical type of injury. So there's no clinical signs that suggest that they've had a herniated disc or that they've endured some type of muscular strain or something along those lines. They have these pain issues, and these pain issues tend to go up and down related to the person's anxiety or stress levels. And then you have other pain manifestations that, just tend to come from brain-based issues kind of in and of itself. So like CRPS being like the like hallmark example when people develop these like chronic pain syndromes without some type of injury predisposing it. But for whatever reason, their autonomic nervous system winds these things up. So like people will get stressed and all of a sudden they develop like Raynaud's, and then all of a sudden they're having this like chronic hand pain. And they're like, we don't know what caused it. There was no infection related to it. And when you get the person's stress and autonomic nervous system calm down, some of these pain syndromes can improve and go away. So it kind of leads us towards like a functional diagnosis by elimination of any type of trauma or predisposing issue that might have triggered it in itself.
Yeah, that's a great explanation for that. I have a youth athlete, a high school athlete that just committed to play baseball in college. So he's obviously a committed athlete. He's a well-versed into health and fitness and nutrition, and he's got some mentorship from his family that played at the most elite level. But he actually just told me, he asked me a series of questions about stuff that he wasn't in for, and he was like, what do you think could be happening if I go out in a semi-cold environment and the whole index finger past this knuckle goes white? And I was like, yeah, let's talk about that. That's so you mentioning like Raynaud's and dysautonomia things is just kind of like, these things are just kind of popping up. And the more you talk to other clinicians, I think not just out of your local community, you start, because I obviously screened him, has this been a problem in the past? He's like, no, I've never had that happen. So that's why I wanted to ask you about it. And you're like, this, why are these things occurring? And there's no consistent reason behind it and things like that. So I think that's a great point, that we need to be on the lookout for just the peculiar things, in our clinical practice. And I think that's why people seek out your practice. In a physical therapy practice, we might be a little bit more along the lines of cause and effect things, right? This happened, and so I got this. But these sorts of things are definitely popping up in the community. That's good that you're getting awareness. How do you communicate with your community primarily to make them to isolate your practice into, hey, you're the champions for those people?
So some of the things that I'll do is just we form a tight relationship with a lot of the businesses that are in our area. So people that we see as allies and people that have like the same vision for what our community should be. So, especially like there's so much like consolidation into these mega conglomerates in the healthcare system. So a lot of people notice that like their doctor's office is no longer, Dr. Chung, such and such MD. It's like Dr. Chung because they are owned by Bethesda Health or some type of mega health system. And when you are just kind of on your own island and you're just seeing like a lot of these places just forming these super conglomerates, it's a way that you could actually form an advantage, because a lot of people do want this like old time feel of healthcare where like they have a strong relationship with their doctor and they're going to their doctor's practice and not like this practice that's owned by Walmart and is, has a rotating set of doctors going through because, it's like they design it so that's like an assembly line, right? Sure. So we kind of take pride in the fact that, we are going to take really personal individual care of our people. And, we make it known to our people that like, hey, we are with you not only through the pain that you're in currently or whatever issue that brought you in, but we are going to celebrate whenever you have a kid. We're going to celebrate you when you have a grandkid. We're going to celebrate with you, 10 years down the line when some of our patients are off to college or even graduating college right now. We're going to give them gifts. We're going to do all these little things that say like, hey, this is about our relationship that we have with each other. And even long after that you're done seeing us, we still care about you. And we still want you to know that we care about you, because, that is kind of at the core of what a lot of us went into healthcare for, right? Is to develop these bonds with people. And we want to get them better, but we also want to be like, hey, we are an important part of your life, not just here to just get rid of your pain and say goodbye forever.
Yeah, well said. Really well said. I think our system has so many advantages, but it also has so many ways that it can get derailed a little bit with just how we deal with things in the United States. What you're talking about is, just straight empathy. Just, hey, not only do I see you as a a source of value to get you better, but I'm here to, walk this journey with you. I'm here to, sharing it with your family experience. I'm here to share with you as a person. I'm going to be your clinical expert, but I'm still human. Yeah. So
Yeah.
that's, that touches a lot of people I know.
And we just had a really recent and like really kind of tragic example of this recently. Like one of my patients just passed away of cancer, and she was one of my very first patients. Like if you checked on one of her like patient ID numbers, it was in like double digits. So like that's how long she had been with us. And she had like loved us to death. She referred tons of people to the practice, and like it was really like a punch to the gut knowing that she had passed away. But she had sent her family members to us, and like when we found the news, like we sent flowers to the people in her family, and we attended the funeral. And it's just one of those things, like even though this person was no longer with us, like we knew everything that was going on because we had kept such a tight relationship with their family. And we wanted to let their family know, it's like, hey, we are still always here for you, whether it's for healthcare or just because we're just someone that cares about you and your family. And little stuff like that, like you don't do it because you're trying to build your business. You do it just because you're like a compassionate human being,
right?
Which is why we're in this space.
Sure. Well, on that note, why don't you walk through your complete kind of background, the synopsis form
Sure.
of your walk into professional practice and where you went, and I know you have some other specialty areas in like upper cervical spine, I believe. So kind of walk people who might listen into this kind of through your background.
Sure thing. So I went to University of Central Florida. I got a degree in microbiology, molecular biology. So always been super into sciences. Like, I always tell people that like from the time I was born, growing up in an Asian household, like you are either destined to become a doctor, a lawyer, or a professor of some sort. So I chose the doctor route on that. I ended up going to chiropractic school because my best friend from high school, he's a second generation chiropractor, and I played baseball together with them. His dad took care of us for like these sports injuries and stuff like that. So I was like, chiropractic's pretty cool. Let me get into that. And during chiropractic school, I ended up deciding to go into a specialty called upper cervical chiropractic, where, basically all we did was we focused on, the top part of the neck. And the reason I love that area of specialty is because like I really liked seeing complex neurological issues. So we ended up seeing a lot of migraine headaches. We saw quite a bit of like trigeminal neuralgia, Meniere's disease, vertigo issues, dizziness issues. And like that stuff was like really interesting and exciting for me because those things, for whatever reason, whenever we did upper cervical chiropractic to them, like they got better, and they got better relatively quickly. So that's kind of my background in chiropractic, and that's all I did was just upper cervical chiropractic for my first 5 years in practice. And then right around years 4 and 5, I actually started to see quite a bit of traumatic brain injury patients starting to come in, and I was just really enamored with the topic. So once I started seeing these patients come in, I kind of just dove all into like, all right, I want to understand like neurological rehabilitation. So I took courses through the Carrick Institute. I became a TBI fellow, and I got my diplomate in chiropractic neurology. So now not only do we see TBI, but we'll see like post-stroke patients. We'll see patients with like Parkinson's and movement disorders. We'll see patients with, all kinds of neurological issues. And we'll integrate upper cervical chiropractic with this functional neurology paradigm. And between the two of them, we have found that we've had, quite a bit of success in a lot of really tough to treat cases. So it's been a really fun journey, just kind of expanding my knowledge base and going into neurology full on.
Yeah, that's great. That's I think that typically I would like to see out of my clinicians that I would refer to take care of my friends and family members is that they have continued on a route of furthering education over time, not just, hey, I've done this really well and I graduated and I have a good reputation, but those people that are seeking out further knowledge base and kind of expanding what they can apply, because every time we keep expanding, then we have new areas that we can adjust and make flexible what we thought might have been rigid before.
Yeah.
So,
And plus, like, this stuff is hard. We get humbled from time to time too, right? Like,
right.
It's like one day we're on a roll, we're like, oh, I'm going to fix every single dizzy patient that comes in. And then the next person that comes in is like, ooh, couldn't quite crack the egg on this one. And
right.
That's the stuff that's just like, all right, where do I go to next in order to try to figure out how I can help the next person that has the same presentation?
Well, and that's a characteristic I notice out of a lot of clinicians that I like to talk to or follow on social media, is that's not a, well, I guess we'll just keep doing things until they get better. It's the mindset of, so I'm obviously missing something, or I need to change something I'm doing out of the norm to figure this out. And a lot of people with our types of brains get into this type of rehabilitation and medicine for that, because it's the puzzle pieces that we like to see, not just, putting things on a canvas, but actually making them fit.
Yeah, no question. And like during my journey through neurology is like one of the things that kind of turned me on to it was following Julia Treleaven's work.
Yeah.
Where she just started talking about the sensory motor components for neck injuries. I'm like, oh, this sounds exciting. And then I just started reading some of her papers, and she's like using this laser on someone's head. And I was like, oh, I gotta figure out how to integrate that into my practice. And that's where then I stumbled into meeting you guys and learning about motion guidance and starting integrating that into some of the rehab that we're doing. And then, that's how I ended up actually getting into, diving into further into neurology, is just because doing my own personal research on concussion rehab, I stumbled onto Treleaven's work, which then, brought me to what you guys were doing. And then, then I ended up going into the Carrick work from there. So like all these pieces kind of got laid out in front of me, which eventually took me to how I practice today.
Well, that's great. I didn't know that aspect of your story. So that's actually good to hear, because she's used our device for some publications, her and that group. That's definitely one great application that we see commonly is, people need to have for diagnostic and evaluation and then treatment, some sort of visual feedback from a laser. And ours usually gets gravitated toward, because then you can not only just put a simple laser pointer on the head, you can use it on the arm or the knee or the trunk or whatever with our system. So that's great. I know you've had some challenges of your own recently. Do you mind getting into a few of those?
Sure.
As you know, I'm following you on social media. For those guys that are out there that want to follow Dr. Chung, he's at Keystone Neuro on Instagram, and at Jonathan Chung, Dr. Jonathan Chung on Twitter, I think. Yeah. So those are great follows if you want to get on there and see him. But walk us through some of the things you've been sharing on social media.
Sure. So back in 2020, we went through a little bit of a health crisis with my wife, where she got diagnosed with lupus. She ended up having like a pretty catastrophic form. So we didn't know she had lupus until she was in the hospital, and she had like a 3-week hospital stay. So, that, was a big stressor on a lot of us. She's doing way better. Like, she's thankfully through, I guess it's another point that I've always wanted to make to people is just like, no matter who you are, like make sure you have someone in your corner that is healthcare literate, because, just from doing my own research into lupus, I ended up pointing her in the direction with a rheumatologist to get this like really, game-changing therapy for lupus nephritis. And since she's been on it, like all of her biomarkers are better, and like her kidneys like are functioning normally based on her blood work now, which is incredible.
That's amazing.
So,
that's great. Yeah.
That's something that we just found out recently, that her blood biomarkers are like, pretty much normal now, which is an amazing thing. And then in 2021, I was the one that was sick throughout most of the year. So I'd been having chronic abdominal pain through most of my life. But last year, it had gotten to the point where it's happening with like really strong frequency. So it used to be like a once or 2 times a year I would get wiped out with abdominal pain. But last year I was having it basically once per month. So I did all these tests. All the tests were negative, and they only found like thought it was an incidental lesion on my appendix. So they would say, well, you know what, we need to go take this appendix out anyway. Let's just explore your bowel while we, go look at your appendix. So they went to go do an appendectomy. And what they saw during my appendectomy is that I had a tumor that was wrapped around my appendix, cecum, and small intestine, and it was creating, transient obstructive bowel symptoms in me. So, they took out, about 2 or 3 inches of my small intestines and the appendix too. And, thankfully since then I've gone 3 months without any abdominal pain. But because of that, because of the surgery, I'm a pretty active guy. I was doing CrossFit for a really long time. I've had to take a little bit of a break from weightlifting. So I've been trying to ease myself back into training again. But yeah, it's been a little bit of a crazy 2 years.
Now, for people who haven't followed you before, and I noticed this as soon as we had a little bit of a familiarity with each other, and I was following you on social media. Real easy snatch form with weightlifting, and pretty heavy weights for throwing. I mean, you're a smaller framed dude. I think we're about the same height, but you're probably 20 or 30 pounds lighter than I am, and you can throw up about 40% more than I can overhead. So you've lifted some pretty heavy weights, but sounds like they're restricting you a little bit from that before for a while.
Yeah. At my peak, when I was Olympic weightlifting, I did a couple of competitions. I had a 235-pound snatch and a 265-pound clean and jerk. So I was something that I was really really because I was just naturally good at it for whatever reason. But yeah, right now, the last time I picked up a barbell, I think it was 75 pounds. So I got some work to do to try to get back to where I was previously.
So what are you doing to fill in the gaps then? Have you moved on to anything else?
I've been spending a lot of time on the Peloton, but my new interest has been Brazilian Jiu-Jitsu actually. So I just started some BJJ training. I'm not going full out on rolling because that puts a lot of pressure on your abdomen, but I've been going through and learning the techniques and learning the forms and stuff like that, and really been enjoying it both from a self-defense type of perspective, but also just from a movement curiosity perspective, because it's putting me into positions that I've never been in before. It's making me use my body in ways that I've never used before. So just the excitement and novelty of learning these new movement patterns, I think it's been pretty cool for me to learn, just from both a neurological curiosity perspective and also just from an enjoyment perspective, and just doing something fun and that involves fitness.
Right. For sure, that's going to be a strong fitness level depending on how far down that training you go. When I was younger, I spent several years in training with Taekwondo, and I ended up getting my black belt, and I went to the Junior Olympics and medaled in sparring with the Junior Olympics. And so there was always that familiarity with what you were just mentioning about, body positioning and, moving in space, but it's a distance martial art. It is you stay over there and we'll have our little, we'll have our point system, and fine, you can kick me in the head, and yes, you got me on that one, and that really hurt. But BJJ is different. You can take someone who has no idea what they're doing, and even though they're much bigger, you can get humbled pretty quickly with rolling.
Oh yeah.
Yeah.
I learned that fast. I was we were covering a technique with it was a beginner's class, and then the instructor, I was the only one in the class. So I was getting kind of a private lesson, but they needed someone to demo on. So he brought his girlfriend in, who is 5'2", maybe weighs 110 pounds.
Yeah.
It's all right, just go through some of these maneuvers with her. And then they did a mini sparring session, and I have 50 pounds on this young lady, and within 2 minutes she would have me wrapped up, and she would be choking me out within a minute and a half. Like, all
With
right,
your own
proof of
gi.
concept. Yeah, proof of concept. This stuff, helps smaller people overwhelm bigger people if you don't know what you're doing.
Yeah, yeah. It's hard to tap out in the street.
Yeah.
It keeps you pretty humble for sure. That's but man, there's something I don't know how I want to say it. There's maybe something genetic or intrinsic uh, for numerous humans, not just guys, but I think it's more prevalent in guys, of just the ability to be able to physically say I can control my own environment, not go out and impart that on somebody else, but just say I can take care of myself, is kind of primitive. I think
Yeah.
there's a feeling of self-worth that a lot of people don't understand if you haven't been put in that situation, because there's always somebody better than you. There's always somebody who has dedicated more to that. And most people that I've met in those arenas are just super nice people.
Yeah.
They're not aggressive people. They are humbled people, and those are people I think we want to keep in our lives for sure.
Absolutely. Absolutely. And I think you're exactly right. Like, there's a sense, especially when, for the most part, the world is safe, but at the same time, there's like people out in the world where they might not have your best interests. And like one of the things that has been prevalent, especially in the past couple of years, is like you have this like sudden increase in anti-Asian violence that's popped up. And like in those types of scenarios, like, yeah, I always want to know that in a worst case scenario that I will be able to protect my family if it ever came down to it. And that was part of the appeal of learning one of these martial arts too, because I never want to inflict harm on people, but for sure I want to be able to know that at a basic primitive level that I can defend members of my family if I need to.
Right. Yeah, maybe that's maybe even gets down to what I was mentioning before. It's hard to put a finger on it without being maybe some sort of social psychologist maybe.
Mm-hmm.
But yeah, it's one of the powers of social media, unfortunately, is the prairie fire that can become hate and distrust.
Mm-hmm.
And it's things that just were very isolated, it seems like, when you or I were maybe younger, kind of growing up, or now like, well, so many people can see so many things so quickly. And
Yeah.
it's everybody always seems to have a slant on it, in media perspective, and things get out of control. What part of Asia is most of your ethnicity from?
So I'm Chinese by background. So
Okay.
my mom and most of my family is from Hong Kong. Um, my dad is also Chinese, but he was born and raised in Jamaica. So I have a little bit of like
Interesting. Okay.
a cultural mishmash there where I have like cultural elements from the islands, but from a, ethnicity standpoint, I'm Chinese.
Okay. Yeah, great. That's great. So were you born in the United States? I didn't know any of this about you. So
Yeah.
just
Yeah.
asking.
I was born in Florida. So I was born and
Okay.
raised in Florida, which, where Florida has kind of always been home for me, besides the 3 years I spent in chiropractic school.
Uh-huh.
So yeah, Florida is, just always what's felt comfortable to me and what I've always known. Like I didn't see snow until I was like 22 and lived in Atlanta. And even then I was just like, all right, I'm out of here for
And you saw
after
snow in
that.
Atlanta. That's fascinating. That doesn't happen too often either.
No, the entire city like shuts down for like a day whenever there's snow in there.
Yeah. So coming from Colorado, I was born in New Jersey, but my parents moved out to Colorado before I was even two. Um, so snow is a thing, and it's obvious, every seasonal thing. But numerous years ago, we found ourselves in the early spring in Memphis, Tennessee, and being right pretty much on the Mississippi. Like, they don't get much snow. It just stays more, temperate in the climate in that area. And you're exactly right. Even in that western part of Tennessee, they had, I think, 2 inches on the ground, and the whole city was just like, nope, we're done. We don't have the resources for this. Everybody stay home for 2 days.
Yeah, I think I heard that like the city of Atlanta has like 2 snow plows for the entire city.
Right.
So like they're like, what do we do with this if like the entire city is covered with like a couple inches of snow? It's like you just wait for it to melt and no one does anything for those next day.
That's exactly right. I'm sure it's gone pretty quick.
Yeah.
You'd have to wonder who has that lazy, maybe ideal job of, well,
Right.
I plow for the city in Atlanta. Wow, what were the qualifications for that?
You might get called into work once every 3 years.
That's right. Yeah, like you're on the city payroll, getting full benefits maybe. Um, good. So, what else is going on? What part of Florida are you in? We didn't cover that yet.
So I'm in the West Palm Beach area of Florida. I'm in a town called Wellington.
Okay.
So right now we're kind of in the middle of peak season, so we see a lot of equestrian patients. So a lot
Oh,
of our people that come in, and this is kind of how I got into the concussion space, is because a lot of people in my town, like they're professional horse riders. So like when you're a professional horse rider, like I think the statistics are, if you're a competitive athlete in equestrian sports, 25% of people are going to have a concussion at some point in their life. So like for them, it's like a rite of passage. Like eventually you're going to fall off your horse, and then, most of them just shake it off and kind of go back to it. But, when people have those post-concussion syndromes, like once people figured out like, hey, I don't have to like continue having persistent dizziness, and I don't have to continue having these persistent autonomic symptoms, we started to make a name for ourselves in the equestrian community for being able to help some of these post-concussion issues when people fall off their horses repetitively.
so walk me through that a little bit. So, the majority, I'd say the vast majority of literature in the concussion realm, over the past 5 years, at least, maybe for the past 10 years, has been highly suggestive of breaking that model of early low threshold aerobic activity. So instead of, just stay at home, rest for 2 weeks, don't overdo it. It's like, nope, we need you back doing something, going for walks, doing something low threshold based, whether we go through a Buffalo concussion treadmill test or something like that to determine that, or just kind of give advice. For what my question is with the equestrian realm, because I haven't thought of this before, with so much variability on the vestibular system and the oculomotor system, getting back to what they want to do, how do you manage that with that population who has a concussion? What are there some baseline measures that you say, hey, if we reach this, then you can get back on the horse, or walk us through that?
So it's actually one of the interesting things I've seen in a lot of horse patients is like they actually have quite a good vestibular system before they have their injuries, because like the bouncing and bobbing on the horse and the fact that their body is constantly having to deal with like this translation of this thing that they're on that could move at any direction anytime. So they have to be super adaptable towards a lot of these sudden movements and sudden changes.
Sure.
So when we actually put some of these patients on like a balance test, so we have like a force plate, and we'll put them through the MCTSIB, which is a modified clinical test of sensory integration and balance. A lot of them actually score quite well even after their concussion, because their vestibular system, my hypothesis is that the vestibular system was already at a pretty elevated level and might have been like exceptional before their concussion happened, but after the concussion, they're not falling drastically into these abnormal ranges. Like if you took just some guy off the street who had a car accident, where their balance scores are going to be in the toilet. So they actually compensate quite well from a balance perspective after a concussion. What I've noticed in them is their baseline neck strength isn't so good. So if I had them like hold their head up 1 inch and do the head lift test, like they fatigue out pretty quickly at around the 15 to 20 second mark, where a lot of our like, football players and strength athletes, like they can hold that for quite a bit longer, but their vestibular systems might not be quite as good. So that's kind of one of the interesting things I've seen in that specific community. As a whole, like for me, I see concussion as a form of dysautonomia, because you have this energy mismatch problem. So someone takes a head injury, neurons inside of the brain get hyperexcitable, but they go through this vasoconstriction process within their carotid arteries and vertebral arteries, where blood flow is going to be decreased going to the brain, even though they have this higher demand for energy coming from these hyperexcitable neurons. Right. So that leads this mismatch problem where the brain requires energy, the body can't get the energy to the brain fast enough, and that precipitates a lot of these cognitive type symptoms for them. So the basis for like the Buffalo treadmill concussion exam and use that rehab strategy is like you're giving this really light autonomic stress that's going to be below their symptomatic threshold. And it's like you're just gradually training the autonomic nervous system to open up those that blood supply up to the brain and allowing the brain to get to that energy source a little bit easier. And then once they've established that physiologic level is kind of under control, then we can start to work through, do they have a cervical injury? Do they have a vestibular injury? Do they have other forms of dysautonomia that weren't just addressed with the sub-symptom threshold type of an approach that we need to address? So once you start to like look at it, then you can start to silo these patients and like, all right, where do we have to prioritize? Because chances are we're going to have to address a little bit of all three, but we'll say like which one seems to be making the person specifically symptomatic. If it's the vestibular aspect, we'll put them on the balance test and we'll say, do they fall off relatively easy? Or I'll do some basic head shaking tests with them, and can they maintain gaze while their head is shaking? If they can't, or it makes them symptomatic, then immediately we're going to prioritize doing vestibular stuff with them. If I go through just a basic cervical exam and palpation is just like their neck is a mess, and then I'll do the joint position error test using your motion guidance laser and they're all over the place, right? Then I'll say, okay, maybe we prioritize the cervical rehab on this patient. And if I just give the patient just a minimal amount of cognitive or cardiovascular loading and they're just blowing out, then maybe we're prioritize treating their dysautonomia as their primary go-to. So based on what each individual patient is showing is kind of where we'll direct our therapies initially, depending on what is, likely the biggest culprit for making them, feel symptomatic.
I really love that answer. It screams what you said, I think twice in that little statement there of just, forming the rehab plan and the treatments into what is necessary for the individual patient. So, a lot of people can say they treat concussion, they treat mild TBI, whatever that is, right? These are the things that we do, but you have to not only understand the test, you have to understand the person, you have to understand when to maybe do more. So like the joint position sense air testing, if your equestrian person is already a super high level, they might pass that test for rotation, but can they pass it for quadrants?
Correct.
And off axis things, can they pass it for, vertical and vertical axis things? I've talked with other experts in the field, and they'll use those types of tests to say, well, you are normal all the way around the clock from 3 around to 12, but from 12 to 3, very poor in that small range. And so you could hide those things on a typical test. And I think we've probably all seen those people that have failed rehab, or they weren't improving before, and then they just didn't get specific enough with something that they understood was, well, they were functioning at such a high level before, we have to kind of grade our tests or look further into that. And it sounds like you do that really well in your practice.
Yeah, absolutely. And like typically we end up with people that coming into the practice that have like been through more traditional rehabilitation type of a practice, and for whatever reason they weren't able to get better. And like sometimes you just have to look several layers and not necessarily just go through like this treatment algorithm and says, well, we did cervical rehab with them, so like if they did cervical rehab but they had poor tolerance for the cervical rehab, like maybe we weren't giving the cervical rehab in a way that their body could tolerate. So we had to modify your cervical rehab so that they could do the exercise without making them flare. So one of the things we'll see commonly is like we treat all of our patients like athletes, and the athlete mindset is, hey, just push through the suffering, and once you get past the suffering, then you'll be better. But in some of these concussion cases, like pushing into their symptomatic thresholds is not really good for them, because you're building up this negative plasticity where now that person is fearful of doing that next movement that's going to push them into their symptoms. And as long as they continue to have fear of that, then they're going to get in trouble because they're going to have this apprehension about that specific behavior. But if we could guide them in a way that allows them to move into this threatening movement or move into this threatening posture, but it doesn't get to the point where it makes them symptomatic, then that starts to lessen a little bit of that fear, and it gives them a little bit of a sense like, oh, maybe I can actually start to move in this direction without, getting sick or getting nauseous or having these types of problems. And then you start to build up self-efficacy, because you just sometimes need you just need to get the patient to believe that their symptoms can be reduced, even if it's just for a short moment in time. And just having that belief can make the biggest difference for how that person is actually going to complete their rehab plan and rehab strategy.
Yeah, I love those words. That just feeds right into my wheelhouse with clinical practice on, because we can't rely on imaging all the time. We can't rely on special tests all the time. We can't rely on a person being the standard person to treat them. Probably the most powerful thing we can do is significantly reduce or eliminate their symptoms in some component, if not multiple components, on day one. Or the person who comes in, they've been struggling for a long time, be like, well, I didn't realize that I wasn't doing this, or I had that deficit. And you do a small retraining via different inputs, or go about it more of a cerebellar route than a frontal lobe route or something. And and they start feeling better, and you're like, this is how your system wants to work. And it boosts their spirits, it boosts their compliance, it boosts your reputation, it boosts everything. So
yeah,
versus always, especially in physical therapy, I think we have a tendency of, if you kind of zoom out, 9 out of 10 treatments that we give to our patients tend to be painful. Like we can needle them, or we can manipulate them. And if you're not super skilled, a lot of times that's going to be a painful experience. We can do deep soft tissue work. We can do, Reiki and, all these types of things. We can use tools. We can get butter knives and stick them into their hips, and, all sorts of stuff. And oftentimes we have a no pain, no gain mentality. But when you start integrating more of a functional neurology approach, you realize that it's more about, retraining the system to function normally. And that doesn't have to be a traumatic experience to do that.
Yeah, for sure. And one of the things that I taught in one of the classes I taught for the Carrick Institute is the brain has to feel safe in its environment in order for the autonomic nervous system to not produce this chronic elevated sympathetic reaction to things. Because if the person is constantly in this sympathetic physiology, their ability to heal and recover is going to be limited. So how do we convince the brain that their body is safe within their environment? And I'll give an example that we had recently is this patient that I saw. He had been getting vestibular physical therapy for this chronic dizziness issue for 3 months, and his balance metrics had gotten better. So they tested his balance, and objectively his balance was better all the way through his care plan, but he still felt very symptomatically very dizzy. So they just they kind of ran out of stuff to do, because you pass the balance test, we don't really necessarily know what to do with you at this point. And when I went through and evaluated him and saw he had this apprehension with a very specific head movement. So we saw that he could move his head side to side really effectively, because the core of his exercises were doing these ×1 gaze stabilization exercises. But when he moved his head in the vertical plane, he didn't like it. He didn't feel very good. It made him feel dizzy. And even though he didn't have any objective positive signs I could point to that said that reflex was broken, all I knew is that he did not like doing that movement, because that movement made him feel nauseous. It made him feel kind of upset, and made him feel which precipitated a lot of those dizzy symptoms. So what we would do is we would just get him to move his head side to side a little bit for a couple reps. And we say, let's just move your head up and back to neutral. So don't even worry about moving your head back down. Yeah. So he moved his head back up and back to neutral, and it didn't make him feel good. So, all right, that vertical plane upward, maybe not so good. So let's try doing this. Let's have you move your head down and back to neutral. Move down and back to neutral. He felt fine. He wasn't under threat with that specific movement. It's all right, well, let's try this. Let's just, instead of having you move your head up and down all the way, let's have you move your head down and back up. And you just stay within that plane. Don't even worry about your head extending into full extension. Just go down and up. We're just going to keep your exercises like that for the first week. And then we're going to see how you do with that. So he came back next week, and he's just felt a little bit less. I didn't feel as bad about it. And he was compliant with all his exercises, which is, super important for us, because If patient's not compliant because that head movement is making him sick, of course, you're not going to do it the amount of times that he's going to need to. It's like, all right, cool. So let's give you a little bit of visual feedback. We know that you don't feel so good when you move your head up, when you're just trying to keep your eyes steady. I wish you just follow the laser, move your head up and bring it back to center and see how you feel with that. So he did that with just putting the laser on his head, didn't change anything else about the exercise, and he tolerated it. So we didn't have him do the exercise fast. You just keep it nice and slow, move your head up and move it back down. If you feel symptomatic at all, slow the head movement down even more. So just make sure that you're just following the laser as best as you can. So now we just convinced his brain that he can move his head up safely without it being symptomatic, as long as he has the stimulus there.
Right.
So then the next week, he feels even a little bit better. It's like, all right, let's take your crutch away. Let's take the laser away. I want you to move your head up and down and just keep your eye on the target in front of you. And then all of a sudden, that up and down head movement was no longer a threat or a perceived threat to his brain. And his brain didn't produce all these physiological signs that make him feel dizzy. So all we had to do was just take him out of this space of, let's make this threatening movement to you that's making your brain not feel safe. And let's start to slowly expand how much your brain perceives as safe before we start to get you into the full-on head movement that we eventually want you to do full time.
Right.
So just convince them it's safe first, and then you could start to bring them into a place where you get them to do the movement that is actually desired at the end of the road.
That's good. That's wonderful. Yeah, that's great. Really good example of tying into what the patient needs, but using examination to drive you there, and then also making sure that your patient understands the criteria of what is okay and what's not okay between visits to, like you said, to increase their compliance, which is going to be critical for those.
Yeah, for sure.
That's fantastic. That is fantastic. So if people are in the Florida area and they need to get a hold of an expert in the field, well, where do they contact you? What's your website? Or I think I mentioned some of your social media handles earlier, but you can repeat them.
Sure. So my practice is called Keystone Chiropractic and Neuroplasticiy. You can find our website at chiropractorwellington.com, and that'll take you to our website. We'll have all the information for making appointments, or if you could want to just get a complimentary consultation online, then you could always, fill out some of the forms that are on there. Like you said, I like posting interesting stuff about the brain on social media. So at Keystone Neuro on Instagram is where I publish most of that stuff. And my Twitter at Dr. Jonathan Chung, I usually just share my thoughts on there about different neurological topics. I'll post interesting research papers if they stumble onto it. But yeah, those are the main ways to get a hold of me. And yeah, I'm always happy to, chat with people, even from out of state, if they have any questions about, a neck injury or a concussion or something along those lines. And, that's something that we'll do for people from out of state too.
Yeah, perfect. Probably the only positive thing I can think of out of the past 2 years, rehabilitation wise, was pushing more toward the development of online platforms to direct some care when you have distances like that. So that has been a silver lining, I think.
Yeah, I think it has. I think it's telehealth stuff is going to be here to stay. And for the most part, it's a good thing for most patients, for sure. So they have access to someone, especially if you live in a super rural area where it's hard to get access to healthcare services.
Right. Well, and obviously I'm biased with this, but having deliverables like we have with motion guidance at least gives people like you something where you can say, well, if we're picking up on this, let me have you get this very affordable tool that you can send to that rural area. Let's have you set it up, point your camera toward this. Let's see if these things are showing up for us, and we can do some diagnosis without having you, take a plane ride or a long car ride or something like that. So
definitely,
we're definitely getting better at those distance things. So
awesome.
Well, thank you so much for taking some time to talk to us and get what you do out there to our listeners and the people that are our followers out there. Please go follow Dr. Chung. He is an expert in the field. He does some amazing work. He's constantly cutting edge since I've known him. And I am just so happy that everyone in your life seems to be getting much healthier, including yourself. So
thank you, Eric. Appreciate it. It feels good to have everyone not be sick for once in the past couple of years. So
yes.
we're happy about that.